So welcome to week 3. It's going to go by pretty quick. At week 3, we're a quarter of the way through. So a lot of information has been covered. This week, we're going to do chapter 22, healthcare adaptations for the child and the family. I will be doing a PowerPoint telling you about all of the information. And then, of course, I'm going to have a Kahoots to follow. We should get done right around 5 o'clock. And then you can do your quizzes. Once you're done with your quizzes, that you can leave. Now, next week, we do have a exam. I've already done a review. It is posted in your announcements, and it's going over the information that you need to understand to be successful on the exam. Now, I've sent you these worksheets, which has like all the definitions on the bottom with blanks. If you follow the PowerPoint, it goes congruently with it. So if you're beginning, is all of those definitions. So make sure that you look for the definition, write them in. If you listen to me, look for it and write it down. You are doing all the types of learners, the auditory, the visual, and the ones that have to do it. So it actually works well for you and your memory to remember these things. I think I describe things very easily, very simply, so that you can understand them a lot better. And that was the comments I got after the review when I did it on Tuesday. I did it on Tuesday at 5 p.m. at 5 p.m. like you had all asked me to. And I did have a pretty good response to it. Remember, Professor Brunel is tomorrow if you want to go to the review. I will be getting that review up as soon as I have her send me the recording. And she's usually pretty good. Within 2 hours of the review, I should have it and post it. I will post it on the same announcement that I posted mine. Okay, so you're not looking in 6 different places for things. I can't stand that. So I'm trying to keep you organized as well. This week you have NCLEX questions due. And you also, the quiz that we'll be doing, quiz 2, and then of course, getting ready for exam 1. When you come in for the exam, you're going to come in on a Zoom. I'm going to check your IDs, whether it be Fortis or a driver's license, to make sure you are who you are, and checking your desk to make sure you're good. So always make sure that those rules of testing you follow, and I'll be posting them again this weekend for you. Also make sure that your laptops are plugged in. I've had students, lose battery, don't have cables, couldn't plug in. So those are things that I remind you out. They sound simple, but it does happen. So make sure that you come plugged in, ready to go. And of course, it is going to be on Exemplify through ExamSoft. So when we are done with the exam, there will be class. And I will be teaching week 4 information. Now, I might do the first class. I might do a lecture. The second class, which is you, I might do the Kahoots. I might do a combination of both. It depends on how much time I have. Usually, we will be doing class at 4:20, or which you would be 7:20, that you will start class, because you start class at 6, do the exam, come back at 7:20, and then we could get the lecture done that we need to do. Okay, so that is my goal for next week. I do want to apologize. I didn't get those PowerPoints out you for this week till late. I got completely forgot, and I do apologize. I did 2 different reviews for PN, for RN. I made the reviews for PN, RN, getting prepared for class, just like you get crazy. Well, I was a little crazy too, but I will make sure that next week's stuff is, and from now on, that I have it out by Monday at the latest, usually by the weekend, so that you could take, if you like to copy those PowerPoints, you'll have it. But for today, I do apologize. So any questions by anybody? All right.
Is there any time you'll have before the actual exam to meet with us one-on-one?
If you want it, absolutely send me a message, and I'll work with your schedule and my schedule to find a time to work with you.
Okay, thank you so much.
especially if you need help with dosage calc. I don't care if you come 1-to-1 or a couple of you come. I make it very simple. You do have the recordings. You do have all the worksheets that came out through the review that students wanted it. So I sent it to all of the PN classes, all of the RN classes. So everybody has all the dosage calc that they need in order to be successful, with those 5 questions. It's 10 points. It's a lot of points. So let's go to our PowerPoint. So we're starting with week 3, the healthcare adaptations for child and family. There's different things we do for adults, for children, all different cognitive levels, and there are little bit of things that you need to be looking forward, thinking about. So I'm going to go over quite a bit today regarding that. Now, the first thing we do when we go into a hospital setting, you have, or an ER or urgent care, you have to sign a consent. Now, if a child is less than 18, a parent will sign a consent. If a child is cognitively delayed, maybe a child with cerebral palsy who's 18, the parent's still going to sign the consent. Now, if the consent is done on an 18-year-old, awake and alert, that 18-year-old is going to sign the consent for treatment. And if a parent wants information about that child, of anything, labs, anything, you must tell them to go back to the child. The child will give them that information, okay? You can't give information because they are in their consent. It's a violation of HIPAA if you do that without that child giving you consent. Now, there are different consents. Now, there's consents for admission, for treatment. There's also an emergency treatment consent, whereas a child comes in, no parents there, and they need immediate attention. Well, by state law, 2 physician signatures suffice as consent. You don't need to wait for a parent to get consent because these children could die if they had to wait. So you can go ahead and give consent. Now, let's say you're going for surgery. Kids, they get tonsils, adenoids, ears, appendix. Those are some of the very common things. The parent and the child, depending, need to be able to say what is going to happen. What is the surgery? What are the risks? What do they want to accomplish with this? And understand, what they're signing consent for. So the physician must talk to them about these sort of things before they sign it. And each signature has to be witnessed. Now, it doesn't have to be another nurse. It's just another person witnessing. If you're going through the ER, you have the ER clerks or the admission clerks that a lot of time, in some consents, they're signing those consents. So just needs 2-person signature. Now, on admission to ER urgent care or into the hospital, a patient's given an ID bracelet. Now, today, there's been a lot of mistakes, medication errors, because patients have not had their ID bracelets on. So many of these units, the ER or the floors, they're doing rounds and doing a review to ensure that every single child, every client has an ID bracelet on. Because if you don't have an ID bracelet on, you're not a room number. You're not in 203A. That's not what we say anymore. It is by the ID bracelet. You're going to ask the child or the parent, what is their name and what is their date of birth? And you're going to match it up to the bracelet. If it's wrong, you're going to tell the charge nurse, and the charge nurse will either get them a new bracelet or call someone who is the appropriate person to put on a new bracelet on that child. You cannot give medications until they have an ID bracelet on, which showing it is the same child. And of course, you always verify who is that child to make sure that you are getting the appropriate one. So getting a chest x-ray, you need an ID bracelet. For a breathing treatment, respiratory coming in, you need that ID bracelet on. So you can't do anything without an ID bracelet in any of these settings. Now, keeping a child safe and preventing falls is a big thing. There's been a lot of things and a lot of studies done on what do we do. Well, in pediatrics, you have a younger child, you must make sure that you keep those crib sides up. Some cribs have a little door at the end. You can open the rails up, but there's a door that you can sort of stick your head into. If a mother moves away, they must make sure that it is closed. So you need to document that you instructed the parent to make sure that the rails are up or the crib side rails up or the door on that rail is closed. If they fall, they're going to be filling out an incident report. It's just a lot more work for you. So make sure that we also do that. Again, you're going to identify the child by the ID bracelet, not by the room. And if you remember conversation regarding toddlers, I call them my dive bomb kids. They like to get up, crawl. They like to get in weird places and jump. Well, they will climb up a crib and try to get out, especially if a toy is on the floor and they want it. They don't realize if they come up over the rail, they could fall and they could hang themselves. They could break a leg. They could do a lot of things. So today, they have these tops that they put on. Sometimes it's something they tie on, but many of them have like this plastic thing. It's like attached to that crib, and it's made for those kids that want to climb over. So make sure that your toddlers have that for sure. Now, these cribs usually have wheels on them because you have to move them from room to room, right? So parents sometimes in their rooms will move them because a lot of times they'll stay and they'll sleep with that child. So they're organizing the room. Make sure that that is not pushed up against like the oxygen outlets that they can get into, those little black ear things they can take out, chew, inhale, choke, or electrical plugs. They can stick their fingers in. So make sure that it's free from all that stuff. Another thing is we're going in and doing our assessments, inspect the crib, the toys. Some parents don't realize there's tiny parts that can come off and they could choke on these things. I can't tell you how many times I've seen even pieces of crayons in ears or little toys up the nose that come into the ER. Even food goes up in their nose or in their ears. It's why they do that. It's just what these toddlers do. So just be aware of that. So inspect them that they're not going to hurt themselves, bouncing around in their crib. So sharp edges. And if there's little small things. Now, medications. We sometimes think it's okay to leave a medicine at the bedside because mom's changing the kid and saying, just leave it there. I'll give it to him when I'm done. Don't do it. What you do is say, I'm going to come back and give them the medications yourself, making sure that they're taking all of it. You don't know if they took it. Why are you signing for it? Did you give it? No. So did the parent really give it to the child? Some do, or they only took half and they told you, oh, they took all of it because they don't want to upset their child. Now, in the hospital, you have playrooms, usually on every floor. And there's all sorts of toys, blocks, trucks, cars, video games. If another kid has a toy, you shouldn't, say, oh, you went home, let me go grab that toy. My kid wanted that, my son, my daughter. Well, what you need to do is, these things are full of germs. Remember I told you in daycare, and especially toddlers, everything in their mouth, all they do is swap spit with the toys, right? They go from one toy in the mouth, from another kid in the mouth. And now it's an infection control problem, right? So we don't want to do that. So making sure that these toys are cleaned with a good antiseptic, whether it's hospital spray or if they're yours at home. Now, oxygen is used on some children. You see a lot used on those children that were born prematurely. The lungs aren't functioning as well as they should, or they've been really hurt by usage of ventilators and oxygen. So make sure that if we're giving oxygen, it is flammable, it's combustible, it supports combustion. So making sure there's no open flames in that room. When you have a kid in a hospital, many of the kids can get up and walk around. And in the halls, many a times, or in these little cubbies, they have wheelchairs or stretchers or even little wagons. Make sure that the kid's not pulling it out and using it as a toy. Number one, it's a safety issue that could hurt themselves. And number two, it's an infection control problem. You know, this was used by other clients. Never leave a kid unattended, whether they're in a swing, or whether they're sitting, you know, at a table or in a high chair. They could get out of it, they could fall, they could hurt themselves. Little kids, remember, by age 7 months, they can roll over, they can roll out of a bed, and you don't want them hurting themselves. I've actually seen a 3-pound premature infant placed on a scale. The nurse turned to make the isolate bed, turned back, and the kid was on the floor. So even young infants can roll. So be very careful with that. Another thing, and it's hard, sometimes you want to prop a bottle, especially children at home, if you have like twins. It shouldn't be done because they can, you know, try to swallow and it could be dripping in the back of the throat and it could cause them to choke. And they're going to choke and vomit and aspirate, and that is more problems. And you should never try to force feed a kid. You know, when they don't want to eat, you just stop. Now, transporting a kid, how do they get to X-ray? How do they go to get an echocardiogram? How do they go to the OR? Well, we know that if the kid is in ICU, intubated, they go on the bed. But if the kid is older, alert, you could put him in a crib, bring him there. Infants are always their cribs, they'll bring them. Or the older kids, wagons, and they have little straps to hold them in there, or smaller wheelchairs. Many a times I'll get a wheelchair and put the parent in and they can hold their young child. And that's usually the safest way because the child is more comfortable there. They feel that comfort. Always with transporting, keep that side rails up. Now, again, if somebody's coming to take your child or you're sent to go take a child somewhere, make sure you check the ID bracelet. Are you bringing the right child? Because sometimes another kid wanders in another room, or they're visiting, or a discharge happened and a new kid's there. So make sure you check the ID bracelets. And then you're going to document. You know, transport team came and took the kid to X-ray this time via wheelchair, via stretcher, via crib, and then when they came back. When you're doing assessment, remember, children are not little adults. They are unique. And doing an assessment, you are going to do it as you can do it. I mean, you cannot do head to toe on an infant. It's not going to work, especially a toddler, and it's not going to work. So if you have an infant sleeping, you're going to look at the respirations. That's just looking, right? Or a quick stethoscope for 1 minute apically, listening to that heart rate. And you're going to hear that heart rate. And then maybe you might be able to listen to their bowel sounds, but do it as you need it. And I think the one thing you need to understand is you can look at a kid, well appearing, sick appearing. You know when a kid doesn't feel well. They're not moving, they're not laughing, and they just sitting there. And you're going, this kid don't feel well. Another thing you can assess just by looking at is, let's say you had a kid had a fever. You gave him some acetaminophen, and it's been an hour. You're going back to check them. Are they good? Do they feel better? Well, if they're drinking, eating, laughing, playing, you're doing good. Now, infants cannot hold their body temperature, especially the younger ones. They don't have any adipose tissue. They've got big heads that lose heat really, really easily. So make sure the room is warm and quiet so they can just relax. When you listen to the chest, just open up the chest. When you're listening to bowel sounds, just open the abdomen. So always just make sure you're only uncovering what you need. And if you talk softly, what I'll do is I'll talk softly, teaching the parent, but talking softly to the infant and in a quiet voice. And they're just listening to this nice voice, and the parent is being taught. So you're using your time really wisely. Infants always are comforted by a pacifier. So whenever possible, give them a pacifier, keeps them calm. Also, they love infant, small ones, swaddled blanket, hands up to the midline. And then, of course, giving them to parents and they can sit there and hold their child. And again, utilize this as a parent teaching opportunity. And you always document your assessment. Again, observation is big, well appearing, sick appearing. And then also look at the kid. As we're going on, we have the previous weights and previous heights. All this electronic records today, it's great because we can see where they came from. Are they gaining too much or they haven't gained enough? Are they tall enough or they haven't grown? Very important things because it could be key things that are happening. Maybe it's their growth hormones not working right, or it's working too much, or maybe the parent's overfeeding or underfeeding, nutrition, looking at that. So growth and development, the growth, the height and weight is one thing. And then the other is those gross motor skills, those fine motor skills. Are they able to almost walk by a year old? Are they at least cruising around a couch? Okay. If they're not able to even roll over by a year, something's wrong, because that should be completed by a maximum of 7 months old. Another thing we look at is that child's behavior, awareness of the environment. Are they quiet, not moving? This kid probably don't feel well, because even young infants will coo and talk to you in their own way and smile, even at young ages. Older kids shouldn't be just sitting there doing nothing. That means something's wrong. So we need to investigate why. Nurses catch up on cognitive delays quicker than physicians do because we're with the kid much longer, right? They only come in and out, gone. We're there all day long in a hospital. So telling physicians can help a child catch up through early intervention. Now, all kids can't talk, or they all can't convey what's wrong, but physically they can show you signs of discomfort, right? It's very easy to see a kid's not breathing well. You usually can hear it, or you can see their tachypnic, or you see their abdominal breathing like crazy and retractions. Okay, that's easy, just looking, right? And hearing. Also, what if they're sitting there, sort of whimpering, grimacing, and they keep banging their head, whether rubbing it or something? Well, it's probably the location of the pain, which could be probably an earache, okay? We always are out for the best interest of our children. Child abuse happens, and I've seen it. I've seen a 3-month-old with a bruise behind the ear that had a fractured skull. And I was concerned, and it was in the ER when I saw this. And I went to the head doctor and told him, and he said, okay, can you take that kid right now for an x-ray, a skull x-ray? And if you see something, put his whole body on one of those x-ray plates. And we do what we call a bodygram, because they're small enough. They fit on a big x-ray plate. That child not only had a fractured skull, he had fractured ribs, a fractured humerus, and a fractured femur. Child abuse, right? What is my goal? Now I could scream and yell at the mother who brought this child in. The mother didn't do it. My goal was to keep that child safe. And in the end, they knew who did it, and that person went to jail. So what did I do? I kept the child safe. In pediatrics, you're going to see abuse, and it's not nice, and you'll never forget it. I'll never forget that little boy ever, because it was a hard thing, because it was him, his twin brother, and his 2-year-old brother. They investigated the whole family. Yes, pretty bad. Anyway, we took care of, made it a better environment. Also, look how clean the kid is. Now, if the kid's playing sports, comes in dirty, who cares, right? But you could tell, do they have dirty, greasy hair, right? You could tell by ways, are they getting basic needs met? Because, neglect is, a house, feeding, clothing, schooling, right? They don't get it, you'll see it in some manner. Now, the history survey. Now, as we're going through the history, this is a time where we can teach a lot. Now, if they're telling me that they haven't had immunizations, the kid's 3 months old, you can ask why, tell them about the importance of immunization. Or if a kid comes in with his brother and the brother's sick, talk about preventing illness on the other kid. There's all these times that we have time for teaching, just looking at the kid, talking to the child. We're teaching parents too at the same time. Many times parents, want to know what they can get over the counter. They're like, what can I do for a cough? Now, there are all different things over the counter, but the recommendation actually today is, just very homeopathic, honey, lemon, for the kids that are able to take it. I mean, honey can't be given on young kids, but those preschoolers type thing, to tell them just to take Benadryl, they've gone away from that right now. And they're only given very, very mild cough medicines today. The one thing is sometimes they have a rash and they want to say, well, what can I rub on it? I mean, I've seen I think it was 7 or 8, I don't remember how old he was, came in with a rash head to toe, and the father had rubbed Benadryl ointment all over the kid. Also gave him a dose orally. This kid came in a catatonic state. It was an overdose of Benadryl. I looked at the kid and I said, did you rub the Benadryl all over him too and give him a dose? And he goes, yeah. I said, okay, well, he's had too much Benadryl. So we took him back and we took care of him and he was okay. Now, as we're doing the history, we always want to know, how have they been feeling? Have they been sick lately? Are they vomiting? I want to know how they're sleeping. If they're 2, well, have you started potty training or are they potty training? Remember, bowels come before their urine. They're able to potty train. How are they playing? Are they playing with toys appropriately? Can they play alone? Can they play with their cousins? Whatever. And can they communicate? Are they able to express what they want? I mean, there are some kids who have gestures. Like I had one grandson who would always just do this. And that was, I want more to eat. I want more. One kid was like this, I want more milk. I mean, it was something that they had, but they could communicate and the parents knew. Now, if this kid's coming to the hospital, I need to know that if the parent has to go home, right? If they're going like this, I want to know that, oh, they want something more to eat. The head to toe survey, it's not really head to toe, as I said. It could be piecemealed here. First are well appearing, sick appearing. What's their color? How are they breathing, right? They're asleep. We're going to quick get breath sounds and maybe heart sounds. Your vital signs. Now remember, you're not just taking a vital sign. Try to interpret what those vital signs mean. So you take a temperature and it's 101. So kid has a fever. So keep that in mind. Well, we're probably gonna need to medicate him with Tylenol or Motrin, right? So keep that in mind. Their weight, is it the same as yesterday, or is it a lot more or a lot less? Keep that in mind. Blood pressure, is it too high, too low? Is the pulse pressure widening? The number between the systolic, diastolic getting more broad in between? The heart rate, is it elevated? Well, he's got a fever, okay, but is the kid dehydrated? What's his color, right? Looking at a heart rate that's elevated on an infant below like 15 months, they still have a fontanelle open. Is it sunken in? Is it dehydrated? Why his pulse rate's up? Are they in pain while that heart rate's up? Or was it just because of that temperature? Because elevated heart rate and respiratory rate are absolutely common, what you're going to see with a temperature. So when you go back to reevaluate after you medicate, the heart rate should come down, the respiratory rate should come down. And now you know it worked. That hydration status, not only is it fontanelles, it's capillary refill. Is it prolonged, greater than 4 seconds? Are the mucous membranes dry? Or do they have sunken eyes? I've seen that, and I've actually seen young children cry, no tears. That is dehydrated. There's not even enough fluid to cry tears. And it's really sad. Poor little thing's crying, and he doesn't even have tears. And it's not that they're faking it. They have no tears. They're dehydrated. Their heart sounds, what do they sound like? You know, I think a murmur is easy to hear because it's more of a sound. And usually a heart rate is right? So if there's a hole between septums of the atrium or ventricle, you're going to hear this big noise. Lung sounds. Is it upper airway or is it in the lungs? So listening to that. Bowel sounds. And then, of course, skin. Any rashes, lesions, bruising, any of that. We're going to take attention to that. So when we're taking a pulse, we could take radial, temporal, mandibular, femoral, carotid. Now, on infants, we're going to take an apical pulse up to the age of 5. We're going to take it for 1 minute. And why 1 minute? Well, their heart rate fluctuates up and down. Your respiratory rate affects it up and down. So a full minute is a good comprehension of what their real heart rate is. So that's why we do apical for 1 minute. Radial pulse is used for kids greater than 5. And it's very easy. It's like taking an adult, no problem. Respiratory rate and character, remember you can look and you can hear. Are you wheezing? Looking at it. Are there retraction, abdominal breathing? Is there, fast, slow? You can count it just by looking. I sometimes will put my hand very open and watch, their chest come up and out if I'm having a hard time. Remember the heart rate, especially like with fevers, with pain, with dehydration. When it speeds up, it burns more oxygen. So remember, children who have an elevated heart rate, it's one of the first signs of respiratory distress. So if there's nothing else going on, think about the lungs, listen to them. So they're saying with infants, the first thing you should do is respirations because you could see it. And then if they're sleeping, of course, heart rate. Now, blood pressures. The size of my finger is one of the blood pressure cuffs you'll see. What if the baby weighs a pound? that will fit around that little child's whole leg is size 0, 0. Blood pressures go all the way up to extra large adults. Make sure when you choose a blood pressure cuff, you take 2 with you. So it has to fit 2/3 of the upper arm. Now, too little or too big will cause the blood pressure to be higher or lower than it should be. It's not accurate. You need a proper sized cuff. Now, children are born with heart rates of 140, 160. And as they get older, that goes down. So they become adults, and then it's the normal 60/100. Their blood pressures start at 60/40 as an infant, and then they work up. So an adult has higher blood pressure, children have lower. And then their heart rate and children is higher, and then adults will be lower. And it's absolutely normal for that to happen. I know that in children, I like to take the popliteal blood pressure. That's on the calf, the lower leg. It's easily, I can distract the child of all ages. I can hold the leg very softly, and you still get a really accurate blood pressure with it. And hopefully we can get the kid not crying. If an infant's crying, have the parent hold it or give them a pacifier, right? Now, antipyretics and giving it. Now, we give antipyretics for fever. Now, your body, when you get a fever, you get sick, it releases prostaglandins. And what that prostaglandins does, it helps with inflammation, it helps with pain, okay? So when you give an antipyretic, it stops that prostaglandins from being produced, okay? So that's why your blood pressure comes down. We know children who have a fever are like adults. You feel horrible. They sit, they don't drink, they don't eat, and they feel miserable. Give them an antipyretic, ibuprofen, acetaminophen, the temperature comes down, they're eating, drinking, walking around, running, the fever goes back up, they're gonna sit again. And that's just what they do. Now, hyperthermia is different than having a fever. Hyperthermia is when, let's say you're in a car and it's hot and makes your temperature, your body go up. It is very dangerous. We do not use antipyretics with hyperthermia. Our treatment is like putting them in a warm to cool bath shower. We don't put them in cold because it's too quickly. But, it'll be a temperature that is cooler than what the body is. We have to decrease that temperature slowly to get it down. If we allow that temperature to be higher, it's going to cause brain damage, and we don't want to cook the brain. We can measure the temperatures in so many different ways. Orally is common for the older kids. Axillary is used. We can use that for, the older infants, toddlers, preschooler. There's also the temporal and tympanic is actually pretty accurate today. We don't use rectal that much. We use it in the brand new newborn infant, but we're not going to do it that frequently because just putting it in and out can cause tearing of the rectal area, and we don't want to do that. Back in 2002, I think it was, the Joint Commission found that children's pain levels were not adequately taken care of, even adults, and they weren't documented. So today, we go in and we do a set of vital signs. We're going to also ask them what their pain levels is. And there's different pain scales for children and for the adults. What's your pain level? 0 to 10. 0 is no pain. 10 is the worst pain in the world. What is it? Well, they'll give you a number. Infants, there is one that you look at. It's called FLAC. It's faces. Are they grimacing? Are they chin quivering? Their legs, are they moving? Activity, are they just laying there and not moving because it hurts so bad? And then their cry and consolability. That's a flack. Then the older kids at preschooler, we do something called faces. And it's the scale where there's pretty faces, and one is a big smile down to a big frown. And all of the faces in between, regarding their smiling or not. And I'm telling you, children do pick out the right way that they feel. They're very good, and kids don't lie about their pain. They tell you exactly. Adults lie, children never lie. Their weight, very important. Well, number one, weight is telling us, are they growing properly? Do we need to investigate because they're not growing or they're growing too much? So weight and height is part of it. Very important. We also know weight is used for medication. Now, in the adult world, you give Tylenol, you give 2 Tylenol every 4 to 6 hours it's needed for fever or pain, right? Not children. Children is milligrams per kilogram is what is usually ordered. So we need to know how to give safe medications. How do we measure the height? Well, infants, I'll just lay them down on the stretcher with a piece of stretcher paper, put their head, put a mark, stretch them, put the heel, do another mark, and then I'll measure it. That's the easiest way to do it. Older children will step on this little thing or this little, either a metal thing that sticks out or a piece of block of wood that will come down on top of their head. Now, be careful. A lot of the younger kids are afraid that thing's gonna bop them in the head. So make it a game. I go under it, go, all right, let me just touch this here. This is good. Oh, look at my number. I got a 7. Let's see what number you can get. And the kid, now it's a game. So now you hold it, you put it when it just touches you. They do it. You got an accurate height. The kid had fun. And that's what you got the information you needed. On infants and toddlers, we are going to do head circumference. Well, think about it. An infant is born with a huge head, right? And the chest is smaller than the head. That's just the way they're born. As they get older, up to about 1.5 years, we're going to see the head now meet the same as the chest. If it's still huge, something's wrong. Is there water on the brain? Hydrocephalus. Is there a tumor in there? Is the fontanelle open? Is it closed? What's going on? So it's something that we do to make sure the kid's head is growing properly. We do it right above the eyebrows, right around, and just very, pull it tight, just very loosely. All right, and there's your number. And we document it. Now, collecting specimens. Now, always before you do anything, you're always going to check your doctor's order. You might think the urine's a clean catch and it ends up being a calf specimen. Make sure that you know what you're doing. Make sure you have the requisitions, that you have whatever supplies you need, and then go ahead and collect that specimen. One of the things that is done frequently is nurses forget to label the specimens with the child's name. They might have the slips in the bag, but the specimens are not labeled. Blood, urine, spinal fluid, I've seen everything not labeled. And guess what? The lab is going to throw it out and tell you to recollect. Can you imagine doing another spinal tap because they threw it out? It can happen. It's a hospital policy. Sometimes I say, wait, I'm running. I'm going to come down now. Let me quick put a specimen tag on it. And then I'm like, thank you, thank you, thank you, because they have every right to throw it out. Also, when you're doing these specimens, make sure, again, you check the ID before you do it. Make sure you check the tags you're putting on specimens to the ID. Put it in that biohazard bag, seal it properly with the proper requisitions, and make sure it is sent to the laboratory the way it's supposed to, whether walked over or if you have a tube system, through the tubes. And if you've taken a urine specimen and you've gotten 30 mLs of urine, write it on your I&O sheet and also document the specimen you have done. You can do urine. We've talked about that. Stool could be many ways. It could be a spoonful of stool. It could be just a CNS or just a swab of it, or it could be put it on this little card. It could be any of those. Blood. Do you have the right tubes? Is the tubes are they when you're doing it, are they filled up the way they should be, or is it too little or too much? It makes a difference, especially when you're looking at bleeding coagulopathies like a PTT or a PT. If it's not the right thing, they're going to send it back. So make sure it's filled up properly. Again, cerebral spinal fluid, make sure that it's labeled and make sure it is carried to the lab. That's one that we carry. You can do wound CNSs, culture sensitivity. Could be just a swab, or they could take it and just mush it on a slide so they can look at the cells under it. You also can take stuff from drains. There's something called a Jackson Pratt, which is this little plastic ball, and you squeeze it and you put on the lid so it sucks and it creates a suction seal, and slowly will let whatever fluid from wherever you have it come out. And you can take a little drop of that and put it in a, let's say, a little sterile cup, and it could be sent also for examination. Sometimes they do that to make sure, well, is that fluid now with bacteria or not? So is the antibiotic working? Always, as I said, make sure that you follow hospital protocol. Now, urine can be used for bedside testing in a diaper, okay? Well, let's go back and look at urine and a diaper and how do we measure it. If we have a diaper, size 1 weighs 30 grams. You take a wet diaper off an infant and it weighs 60 grams. So 60 minus 30 is 30 mLs of urine, and that's accurate, okay? Now, you can take a little piece of the cottonish stuff in it, put it inside. I usually use a little 3cc syringe, push it in there, put the plunger and squeeze hard. And I can just do one of those little urine sticks. I can look at glucose, leukocytes, ketones. It's like doing a urine, but it's like bedside. It's something that they do like in the newborn ICU every shift is something they do, but it cannot be used for a urine specimen in the lab. You cannot do a regular urinalysis on it. They need that clear urine from the child, whether it's that clean catch or whether it's a catheterized one, okay? So that's urine. Now, when we talk about medications, you know, one of the things about medications in the elderly and the infant, they're really similar. Their bodies don't work as good as they should. The infants, they're not mature yet. So how the drug is absorbed and given to the body and metabolized in the liver and excreted through the kidneys is different. And there are things that can cause a slowdown and a buildup of medication in the body and cause toxicity. And it can cause a lot of issues. So knowing that children have these immature body systems, be aware of side effects and toxic side effects that can occur to children, okay? So younger children are more apt for toxicity than, you know, as a child gets older. We've talked about just even the bowel, right? They don't absorb food in it till after 6 months, and even a little longer, some of the foods, up to a year or so. You'll still see chunks in their stool. That means they haven't absorbed it. So knowing this, we have to be very careful on medications and make sure that we are giving milligrams per kilograms and we're giving safe doses. Their stomach slower. Their intestines, it goes right through. It's fast because it's not absorbing the younger children, right? As I said, topical medications, be careful. More doesn't make it better. Just a little bit works. Can you imagine if you're putting a steroid cream on and the kid's getting all the steroids, you know, and you don't want to do that either. Parenteral or anything with a needle I call it prick. You prick somebody with a needle. So it's anything with a needle, IM, IV, sub-Q, they get absorbed quicker than it would be by mouth. Metabolism, you metabolize in your liver. We know their livers are not mature, and they're saying it's not mature until they're about 2 to 4 years old. So again, we know a lot of that medicine stays inside the body and it can build up. Excretion through the kidneys. Again, kidneys are immature for children less than 1 year old. So we have to be careful. So if you think about the whole combinations of giving medicine, their stomach is slow to empty. It zooms right through the intestines, so it's no time to be absorbed. We don't know how the liver is going to be able to metabolize, and we don't know how well that child's going to excrete medications. So you have to be on alert for a child, especially the younger ones, on toxicity. That's why we do a lot of drug levels, looking at, is it level too high? And nurses are the eyes to see these things. So always observe for any toxic symptoms. And then you're going to look, is it working? Is the medication working? Is it not working? Well, let's do a simple one. You gave acetaminophen, had a fever of 103. You go back an hour later, the kid's playing, eating, drinking, temperatures 99. Did it work? Yes. All right. The kid's still sitting in the corner, still has a fever. That kid, it didn't work. You're giving antibiotics and it's the 3rd day and the kid's still having fevers. Maybe it's not working. Maybe it's something to look at, right? Always, always be careful giving children medications. I know when I was like concerned, I would always ask another nurse, even if it wasn't a high alert medication. I want to be safe administering medications, especially to the young ones. Now, parents will be sent home. They'll be sent home giving acetaminophen, ibuprofen. If they have long withstanding history, seizures or diabetes, they need to go home. They need to give these medications. If antibiotics, when do you give it? How often do you give it? What I have always done, especially when I worked in the emergency room, and I'd get these children in, parents have been working with these kids for 4 or 5 days. They're sick with fever, don't feel good. Finally, they go to the ER. They've gone to the doctors twice. They finally say, I'm going to the ER. Nothing's going on here. Parents are tired. The kid's still sick, don't feel well. So we're going to find out what's going on, give them medications if needed, and send them home. Now, we need to teach them, how is that child going to take those medications? How are you going to encourage compliance, especially if it's a 14-day dose of antibiotics? A lot of kids don't like it. So I know that we could teach them, let's say, I want to give a liquid antibiotic as a younger kid. Have a kid pick out the flavor. I mean, it'll make a difference. Or do they want it in a cup? Do they want it in a spoon? Do they want it in a syringe? Do they want to take it themselves? Put the child involved with it, and the kid will do a lot better taking their doses of medication. Another thing I do is, especially if there's more than one adult in a household, to prevent double dosing, right next to the medications, have a paper. And when you give a medication, write it down. Whether it was acetaminophen, ibuprofen, antibiotic, or their normal everyday Dilantin, whatever it is, so that the person coming behind knows, oh, they already did that. And there'll be no double dosing. These kids are tired. The parents are exhausted. And most of them have to work with sick kids and being awake all night. So they're not remembering what's going on. And if it's day number 10 of giving this stuff, you don't remember if you gave it or not. Yeah, did I give it? Or was that yesterday or the day before, right? We have oral medication. We send them home on that. That's very common. We have intravenous that we give, as RNs, we'll be given IV push, but as LPNs, you'll be hanging those antibiotics, on the secondary pumps, and you could give them that way. Set it up, make sure they're given at the proper time. Nose drops, make sure the kid's nose is clean first, or they blow their nose, and then give the drops. Ear drops, do you know how to hold the ear? Do you remember that? Up and back for younger kids, and then we could give the ear drops. Eye drops, make sure we pull out the canthus so we can give them properly. Rectally, make sure we get it through that sphincter, take the wrapper off, lubricate, hold it in there so it will dissolve. And sub-Q and IM injections, how much do you give? How much is too much? And where are these areas that we do give these medications? I mean, the young kids is all vastus lateralis, big, fat, chunky thighs, hopefully, right? When you get to adolescents, IMs can be given deltoid, depending, unless they're skinny, right? We do have what we call saline locks, intermittent IV antibiotics that we give. Hook up the IV, give the antibiotics, make sure that we flush it before with a little bit of saline. Doesn't have to be a lot. Flush it a little bit afterwards. Make sure it's not red, swollen, or leaking. Those are good things. In pediatrics, I have seen Broviacs, ports, and PICC lines. Lots and lots of PICC lines. And ports usually are your cancer kids. Broviac are usually that interim that's going to be sick for a while, but not long term, that they stick those in. Again, remember, sterile procedure, wearing gloves, mask for any changing of tubings, etc. Very important. And the flushing before and after, so you don't clot these lines off. These are the maximum amount that you can give these kids. Now, an IM injection of 0.5 mLs for some infants, that's quite a bit. Okay, if they're bigger, maybe a little bit more, but remember, too much is going to cause irritation, can cause skin necrosis. I've seen really bad side effects from too much injections. Toddlers, an ml, and then school-age adolescents is in the arm, right? 1 ml, and you could put up to 2 mLs in an infant's vastus lateralis. That's the upper outer thigh. One of the most common that I see given to infants, besides immunizations, of course, but usually it's an antibiotic, Rocephin, ceftriaxone, right? Well, today what we do is, because it burns, we put it in lidocaine and we dissolve it and give it, and then it doesn't hurt. I mean, it hurts for a second and then the pain is gone. And you can put 2 mLs in, and it's not going to hurt that child. Remember, IV medications that are given are directly there. You can't get them out. It's the quickest route of administration. Before any IV medications are given, we have to make sure the IV is patent. It's not red, it's not swollen, it's not leaking. And we know that IVs left there for too long cause an inflammation of the vein, or it's called phlebitis. Any child with an IV needs hourly IV checks. If you think about, let's say, an infant, and you're giving them 10 mLs an hour, if you let that go for 3 hours and not look, and it's infiltrated, 30 mLs could take an arm and puff out a hand like this and could cause skin necrosis, the skin to fall off. I've seen it turn black, and I've seen the vessels and veins and tendons in kids' arms from IV infiltrations. So make sure that we do check them. What they do is sometimes, and it's not that much anymore because everything's on a pump today, but if we don't have a pump and we put it in this little plastic thing, we could put like only 2 hours of IV fluids in there, so that in case it just dumps in, maybe somebody opened up the roller clamp and it just dumped in the child, not so much is going to go in. Because if you have a 500 ml bag and it goes all in on an infant, you've just put that child in congestive heart failure. right? Lungs going to fill up with fluid. It's too much fluid. So using this little burette, it's called, is something attached to the bag. It's this long skinny tube, and you put a little bit of fluid in there, 2 hours worth. So only a little bit can go in, okay? Always, as I said, redness, swelling, looking for any leakage, very important. And you're always going to keep IV fluid. You're going to do ionos. Now, getting a kid, putting an IV in. Now, as I said, the last 10 years of my career, I worked in a pediatric ER. I started many IVs on all age children. And infants, I would have mom holding hand, pacifier, somebody hold the hand. I would stick the IV in and I would tape it in a manner that the child couldn't stick their finger and get it. But I would keep the site open so I could evaluate it. Just don't cover it up with tape like crazy. You can't. You still got to look at it, right? Older kids sucking their thumb, I'm not going to put an IV in the hand with a finger where they suck, right? I'll use the other hand. Things to think about. Telling a child about the IV. Now, many pediatric facilities have child life, and there are people which teach children on their developmental level about procedures are getting done. Let's say I don't have access and I've got to take a 4-year-old and put an IV in. Well, I'm going to prepare them on their level, sit down, and I'm going to tell them what I'm going to do and what's going to happen and what they're going to feel. Now, today we use numbing stuff. At the hospital where I was at, we use something called a J-tip. It looked like a TB syringe, tiny little syringe. And in it, you put a little bit of lidocaine liquid. And on top was this thing, when you popped it, it forced air and forced that liquid into the skin. It doesn't hurt. It sounds like a soda can opening like that. And it just numbs that area. So when you put the needle in the skin, they don't feel it. So they feel touch and they feel no pain. So I make a joke out of it. I'm like, okay, remember I told you this thing's gonna make a noise. I'm gonna put it here now. I bet you jump. And he goes, no, I'm not. And I do it and they jump and we start laughing. So now, we've made it fun. Then I'm saying, okay, I'm gonna hold your hand. Don't worry, it's not gonna hurt. And I'm gonna tape it on. And just plastic is gonna be left there. There is no more needle, it's gone. And something they do really well. Make it a game, make it fun, and then of course put a Batman sticker on the IV board if it's a guy, or a princess sticker, if it's a girl. Doing those things really make a difference. And as I said, making sure that you put it in a place where the kids can still get around, do what they need to do, makes it easier. Making sure that it's taped so that it's not going to pull out, especially if a kid is mobile, up and moving around with an IV pole. And making sure that you still can see the site so you can assess it as you need. Medication, right? We learned this pharmacology, right? We got to make sure, number one, do they have an ID badge? And I'm going to check the name and date of birth. If they don't match, I'm not giving medication. I'm going to alert the charge nurse and get a new ID badge for that child. There's 2 types of way of giving pediatric drugs. We have the BSA, or the body surface area. It is the most accurate, but in hospitals, you will always see milligrams per kilogram. And I always go back and check those doses to make sure they're safe, okay? So I'll make sure what is the dose and if it works out the way that they have it. Today, when you have children weigh, they're always done in kilograms. So you never have to convert. But we know pounds is more than kilograms. So if you weigh 44 pounds, you convert it, you divide it by 2.2. That kid weighs 20 kilograms. So it's very easy to convert. Dimensional analysis is here. I don't use it. I use regular, math. It's on the recording I sent you with the handouts. use whatever works for you. I don't want to change you. But if you need help, ask me. Look at my recording. Look at those handouts I gave you. You still don't get it, please let me know. And I can very easily, I'm not going to keep you for an hour on Zoom. Your time is busy, but I will do it in a manner that you can understand it and succeed and get all 5 questions correct. So in IVs, same thing. I've already gone over it. Now, drug interactions. Now, some drugs cannot be exposed to sunlight. So there's one drug I'm thinking of. It's used in the ICUs. It's been used for children. Nitroglycerin IV has to have foil wrapped around the tubing and the syringe because sunlight tends to deem it impotent. It doesn't work. So knowing those things. Another one I'm going to tell you about, we've talked about Rocephin a couple times, right? Well, Rocephin is a common drug. It could be given IV, as in, IV piggyback that you could hang. Now, Rocephin cannot be given with Ringer's lactate IV. So again, it's something else to know about. If you're taking an anti-seizure drug, phenytoin, Dilantin, you cannot take an antacid 2 hours before, 2 hours after is when you can do it. You can't give it with it because it coats the stomach and it deems it useless. So we can't do it. Iron supplement and egg yolks. Another thing as an interaction is iron supplement. If you give it with bran deems it not working too. So no Raisin Bran for this kid when we're taking iron supplements, right? And iron supplements are usually because you have iron deficient anemia. So you don't want anything to prevent the iron from being absorbed. Gavage feedings are very common in pediatrics. Many infants, especially the newborn intensive care unit, they can't suck, swallow, and breathe. These infants are obligatory nose breathers. So they're trying to, suck, swallow, and breathe. And if it's full of mucus, they can't. And a lot of times it's just breathing is hard on them. So they're like, all right, the kid's not old enough yet. Let's put in a little tube into their stomach and let's give them some food. And that nutrient goes right in and we know they're getting proper nutrition. Gastrostomy tubes are also used. There's many conditions. Let me name some. Pierre-Robin is a syndrome, or DeGeorge syndrome. Their mouths and their tongues, the way that they're made, sometimes they don't have that ability to chew and swallow, and they gag, they choke, they aspirate. And there's other things that can happen, like misconnections that can happen, and they can't swallow without going into their lungs. So they put in a gastrostomy tube because nutrition is number one. We need them to have nutrition. So we give this nutrition and make sure that we don't give it quick. Can you imagine you ate in 2 minutes flat all your food? So give it over a little time. Don't just dump that liquid into that stomach because it'll hurt that poor tummy. And if you're seeing weird drainage coming out of that tube, something's wrong. Tell the nurse to tell the doctor so we can do something. Enemas can be given to children. The one thing a child can do is to control their bowels, believe it or not. And you're like, well, I've seen 7 to 10 days, no bowel movements on kids. And you do an x-ray and you see the whole descending, transverse, and ascending colon full of stool. And you're like, that must really hurt. And you can feel their bellies. You can feel the stool in it. It's like, why do they go so long? Well, what they say is children who do this want attention somehow. There's stress. Something's going on in the family life. Something's happening. So they want attention. So they hold their bowels so that they get that attention. Maybe they want that one-to-one with a mom. Who knows? But we do give an enema. We give pediatric fleas It happens to be the brand Fleets, but it's a smaller, it's not an adult size, it's a smaller size. And we give it and then put on a big diaper because they're gonna go and then they're gonna move their bowels. Now, we don't wanna do that a regular basis. At that time, we'll tell parents to increase fiber in their diet. Sometimes if it becomes a chronic problem, they might put them on some medication like a Miralax, which is just a little bit of fiber in, their drink in the morning. And then respirations. Now, as I said, infants are obligatory nose breathers. If their nose is all full of mucus, they can't suck and breathe, right? It's impossible. They don't know how to breathe through their mouth. They just haven't figured it out yet. It's all in the nose. If it's full of mucus, they're struggling. So we would be suctioning their nose. Now, there's a little bulb thing that just goes on the outside we can do. Sometimes that's for the older kids. We'll tell them blow their nose or here, blow and let us suck it out. And I'll have them help me. And you'll see these kids, learn how to do it themselves. And actually I said, come on, let's see how big we can get a booger here. Come on, let's get going, and they have fun with it. Now, sometimes we have to take and put a catheter down there on the infant to get the whole airway clear out. Remember, if we do it too much, you're creating irritation and then the mucus is going to be more. So be careful. Remember, if you have a trach, the hole into the neck because they can't, breathe through their mouths, whatever reason it was for. Make sure that when we put the catheter down, we do not have suction on for more than 15 seconds. And 15 seconds is a long time not to breathe, right? So be careful when you're doing it. Sometimes there's conditions they're born with. This tracheoesophageal fistula is a connection, a tube that connects the trachea and the esophagus. So when they eat down the esophagus, it goes over the tube and into the lungs. Now you have aspiration. You are not going to feed that infant because it's going to go directly into those lungs until that's corrected. Sometimes there's all sorts of things. There is the trachea, there's an issue with it, narrowing, stenosis, all of these things. We will not feed children, and we're just going to try to keep that airway as clean as we possibly can. Suctioning and, of course, respiratory therapy goes with all of that. Now, respiratory distress. First thing you're going to see is tachycardia, because the heart's going to try and beat faster to get more oxygen around. But they're having issues. Something's going on with the respirations. Is it wheezing? Is it asthma? Or is it croup? Is it pneumonia? Is it upper respiratory? What's going on that's not giving enough oxygen? So you see, number one, the heart rate goes up to try to compensate. Well, then the heart gets tired. And all of a sudden you're going to see bradycardia. That kid's about to code on you when you see a younger child with a low heart rate in respiratory distress. That kid you worry about. I would call the code team now before it happens. Another thing you see with all ages is restlessness. It's called hypoxemia. If you're not getting enough oxygen, you're restless. You're like searching. It's like being underwater trying to get up and breathe. That's what it sort of feels like. They become very restless. As I said, heart rate is up. They're going to be tired. They're going to be dyspneic. They're going to be retracting. Their color is going to be horrible. There's no oxygen, right? They're cyanotic. Now, sometimes you swallow something and it occludes the airway and the kid can't breathe. This is like the Heimlich maneuver, abdominal thrust. Let's get it out of there. It could be they swallowed a quarter. I can't tell you how many quarters I've seen swallowed in my lifetime. Many of them. Some go down there and sit there in the esophagus, and some they'll occlude. And the parents will abdominal thrust, they'll back thrust, and then they'll abdominal thrust to get it out, and it will fly. It's like the Heimlich that you see in adults. Now, children do go to the OR. They need to be prepared. Don't think because they're so young that they don't need to know. Parents go with them. The parents are afraid. The kids can feel the parents being afraid. So let the kid know what's going on. Get them ready for it. Tell them what's going to happen, that the parent can stay with them to the end and they'll go to sleep. Children have this feeling that when they bleed, they're going to bleed and die. So now they're being cut open with surgery. They're going to bleed. They're going to die. So I always say, I'm going to tell the surgeon to put an extra stitch so you don't bleed. I also will say is, that appendix that you're getting taken out, I said, it's nothing you did wrong that caused it, because especially school age children feel this. And I'll say, it's just something that wanted to come out. It wasn't you. So God isn't punishing you, because that's part of what school age children believe. So I will prepare them. Now, answer any questions that they have. By this time, they're already feeling better with just those comments. Now, adults, you have them NPO after midnight, all of them, procedures, everything. Children, no. Infants cannot go more than 4 hours without eating. Usually it's 2 hours with clear liquids 2 hours before, which means Pedialyte, a formula-fed infant, breast milk is considered a clear liquid for infants. So they can have a breast milk 2 hours before because their blood sugars drop. They can't have it. Also, give them a pacifier, self-soothing, right? Now, post-operatively, let that kid know what's going on, what pain medicines are available. Also, with pain medicine, remember, it's just not the pain. It's also maybe positioning, elevating the head of the bed, giving them a pillow for their tummy. Maybe it's a hot pack, a cold pack. It's something. Maybe we need to turn on, cartoons on the TV, distract them. But making sure they know what's going on and they're in control. Older kids want that. They want to know what they can have and not have. And you think a 2 or 3-year-old don't understand? I'm telling you, they do. And that was your PowerPoint. My voice made it. Thank you. Any questions? So everybody, Amber, I need a last name on you and I need your camera on. Or you get no credit for today. And I don't want to do that. Amber, can you put your last name on your thing here? The way they take attendance is my Zoom attendance sheet. And if the Zoom attendance sheet only has Amber, they don't know who you are, and you'll get negative 150 minutes. And I don't want to do that. So I'm always checking for you to make sure. Do I need to do it for you, Amber? I can. Turn on your mic so I could hear you.
I said, I hear you, but I already let you know that I wasn't even gonna, I'm just now getting out of an appointment.
Okay, give me your last name so I can make your name on your
Tolbert,
Zoom.
Tolbert.
Perfect. All right. I want you credit for your time here. So thank you very much. I hope your daughter's okay.
Thank you.
All right, here we go for a Cahoots. Who wants to win? Nobody? Cheyenne, you want to win today, don't you? No. Maybe.
I will try.
Okay. I believe there's 25 of them.
Do we get breaks in your class?
What I do is I let you go home early.
Okay.
I mean, if you want a break after the Cahoots for a second before a quiz, that's fine with me. I just know that most students have requested, if I get you done by 5 o'clock, 8 o'clock or 5 after 8, that's better so that you're out earlier. That's what's usually has been said. Is that okay with you, Ellen?
Yes, I was just unaware of what was our break time because I know everybody is expressing that we got to follow the rules, and I'm like, okay, do we get a break? So that's what I was in question about it.
It's not a problem, Ellen. I appreciate the questions. I just want to get you out earlier so you can go on with your evenings because most of you have so many things to do. And you know, anytime during class, if you have to go to the ladies' room, get something to drink, get something to snack on, it's okay. I understand that. I do not mind it at all. You don't have to be sitting here professional at all times, not eating or something to drink. I get it. Okay. All right, let's get going. Week 3. What is the best pulse location for the nurse to use when assessing the pulse rate on a 12-month-old infant? Remember, it's apical up to 5 years old for 1 minute is recommended so that you get a really good counting of the pulse. What is the definition of a latchkey kid? Now, if you were in my review on Tuesday, I actually went over, it was the last thing I said in that review. I mean, this is a situation that's common today. I mean, most of you have, if you are lucky to have 2 parents, still everybody has to work. So that's the child who's home alone after school with no adult supervision. And remember, when we talk about those sort of things, we're going to worry about accidents and injuries that can occur. So making sure they know what phone that they can call in case of anything. A 9-year-old needs a lumbar puncture. What position will the nurse explain the child will assume for this procedure? And this is for any age child. I know many times to assist with them, I'd take my arms underneath their knees and I would hold their neck and pull it down and say, I'm just going to give you a big hug, and let the physician do their thing. You want it with the knees bent and the head closed because you want to arch the back, and it opens up the spinal bony prominences. So the spaces in between are easier to get a needle in, and it works easier that way. Positioning is all makes a spinal tap easier or more difficult if not correct. An infant's dry diaper weighs 2.5 grams. The wet is 47. How would the nurse record the infant's urine output? What did I tell you about dry diaper and wet diaper? The subtraction between the wet and the dry is the urinary output, and then record it. So it is 44.5. Does everybody understand that now? Just minus 2.5 from 47. Or, as I said before, number 1 diapers, 30 grams. And if your wet is 60, 60 minus 30 is 30. Very easy. And that's in mLs. Gram equal ml. A multi-select. What medication should be checked with a second licensed nurse prior to administration? These are what we call high-risk medicines. Any overdose of these can be life-threatening. So vancomycin is an antibiotic. Although it's a dangerous antibiotic, it's not a second check. Digoxin, too much can decrease the heart rate severely. Heparin is a blood thinner. You can bleed out a patient with too much blood thinning. Insulin, drop your blood sugar too much. And IV morphine can stop a patient from breathing if it's too much. I have seen many errors in giving these medications. So I know nurses that have given a medication error. It affects them for their whole careers. So make sure that you do check, because it can have mental problems for you, and I don't want that for you. A multi-select. A 3-year-old patient's admitted to the pediatric unit with a fever of 103. What actions will the nurse implement? So we have a fever. Sometimes when they get a fever, they get very lethargic, because remember, they're getting hypoxic because the heart's beating faster. Very important to check the level of consciousness. Skin turgor is going to tell me the dehydration or their hydration status. And of course, we are going to give some sort of Tylenol, acetaminophen, or ibuprofen, get that fever down. And then we're going to go back an hour later and we're going to assess. Is now the child awake and alert, and they're moist, and moist lips now, and heart rate's decreased? All of these things we'll be checking. Did it work? What strategy may the nurse use when administering oral medications to a child who's reluctant? So it's sort of a reward, right? Give them fruit juice, or I've got a popsicle when you're done if you take it, or I've got a sticker, something. It does work with children. Very good. Ampicillin, 400 milligrams PO every day, and the vial says 125 milligrams and 5 mLs. How many mLs per dose? Well, let's set this up. What do you want to give? You desire 400 milligrams. What do you have on hand? Over 125 milligrams. And then what quantity come then? Times 5 over 1. So you multiply 400 times 5 divided by 125. Answer 16. Did everybody follow that? Does everybody know how to do a simple desire over have times quantity? Let's do another. Order penicillin, 150,000 units. IMBID, and you have 600 units in a 5 ml vial. Again, what do you have? What do you want to give? 150,000 units. What do you have on hand? Over 600,000 units. And then the quantity is times 5 mLs over 1. Multiply 150,000 times 5, divide it by 600,000. Answer 1.25. Is people following me there? We got another. Lovenox, 50 milligrams sub Q, Q12. You have 100 milligrams and 5 mLs. How many mLs per dose? So it's 50 over 100 times 5 over 1. So 50 times 5 is 250. Divide it by 100. Answer is 2.5. Okay, you will see questions like that on your exam, so just be aware. A parent says, I'm not sure how to give this medication to my infant. What's the best response from the nurse? So when you give medicine to an infant, you put it in a syringe and you put it to the side of their mouth, and usually they'll try to suck on the syringe, and very slowly you give the medicine. If you take it and squirt it in the back of their throat, they're just going to gag, choke, and vomit, and you don't want to do that. So slow and easy, and they will take it. They like it. A 6-year-old takes iron supplements. The nurse advises that which food decreases the absorption of iron? Did you know that orange juice increases the absorption? Orange juice, actually, they recommend you to take with iron supplements, especially the liquid ones. But no Raisin Bran, right, with iron. So if you're taking an iron supplement, you should not be eating bran because it decreases the absorption. And if you're taking iron, you're probably iron deficient anemia, and you need that iron. The incoming night nurse gets the report on his patients from the day nurse. Which finding requires immediate attention? So a widening pulse pressure is part of a child that is about to go into shock. That means the systolic and the diastolic numbers are becoming farther apart. And that is a telltale sign something seriously is about to happen. Now, an adolescent with a respiratory rate of 28, yes, it's high, but it is acceptable. If it was 40, I'd say, yeah, maybe that one at the same time. Get the charge nurse to see that one. Infant heart rate of 100, at sleep they can be, and that axillary temp is normal. A 15-year-old returns to the unit following a lumbar puncture. What initial position should this patient be in? So initially they should be supine. If you've ever been given a spinal anesthesia, very similar to taking fluid out in a lumbar puncture. If we sit them up too quickly, they're going to have a massive headache. So they want them on their back, flat, and slowly raise their head of their bed. And they should be getting either IV fluids or oral fluids so that they're replacing the fluids they took out during this lumbar puncture. These children can't get up and run around right away because they'll have that spinal headache, which is horrible. I'll multi-select. Informed consent for a minor guarantees that the parent or legal guardian understands what aspects of a procedure. So informed consent means they've been informed. They've been informed about the risks, the purpose. Of course, it needs to be signed and witnessed, and that they got information. It does not guarantee that no suit can be brought for damages because there still can be malpractice that occurred. It's just telling you what's going to happen and the risks involved with it. The nurse notices her 2-month-old patient does not have an ID bracelet. What should the nurse do? This is one of the quality assurance things that every hospital unit does on a weekly or a monthly basis, going around checking, making sure that all patients have ID bracelets on. So we are going to confirm the identity with the parent, making sure the name and date of birth, tell the charge nurse, and they will make sure either to make one or to call the person up who needs to put on a bracelet. Could be the admissions office. I mean, every hospital is different. Gentamicin eardrops are prescribed for a 4-year-old child. How would the nurse position the auricle? You remember pharmacology? I told you to. So you pull it up and you pull it back. Okay, that's what you do for a 4-year-old child. You want to get it into that ear hole there very easily. Why is a tympanic thermometer considered more accurate than other types of thermometers? I know when they first came out, most nurses were hesitant to use them. They're like, how can an ear thing work? Well, then we found out that the circulation shared with the inside of the brain. We're like, well, it must be an accurate thing. So this is the reason why. It shares circulation with the hypothalamus. So we know if the inside and outside in the ear, it is an accurate thermometer, an accurate number. Which intervention is correct when a nurse is administering a gastrostomy feeding by gravity? So we're going to position that child on the right side. And let me tell you why. The stomach is on the left side. So you put them on the right side, you're alleviating pressure on that stomach, and you're not going to have that regurgitation. Think about a 2-pound baby, giving them an extra 2 to 4 ounces of water before the feeding. You have just overfed that child. The stomach now is huge. They're definitely going to vomit. You might put, 2 mLs. You're not going to put a huge amount of fluid down there. How often should a child who has continuous IV infusion be assessed? You need to be checking it every hour. And most computer documentations now have a checklist that you check that you've done it every hour. Because remember, a little bit of fluid on an adult is not a big deal, but we even do it every hour on adults today. But the smaller kids, it can cause a big swelling, a big infiltration. And I told you, I've seen the whole top of their hands fall off. I've seen the tendons, it turns black. And then now you're into dressing changes and incident reports and plastic surgery, and it is a big deal. Which intervention will the nurse implement when suctioning a tracheostomy? That's a tube that goes into the trachea from the neck. So the thing is, we're never going to reuse it because it is a sterile suctioning, okay? And we are going to be not suctioning the thing occluded for more than 15 seconds because they can't breathe. So they're not breathing for 15 seconds. And we don't do any regular anything. We suction as needed because too much can create more irritation, cause more phlegm in there. And we don't suction for 2 or 3 breaths. No, We go in, we suction, get what we need. Hopefully it's one time and we're done. What emergency action should be implemented for airway obstruction in the infant? So it's 5 black blows and 5 chest thrusts. We want to make sure that we can get that stuff out. It's like a Heimlich, but now it's back blows and it's chest thrusts for the infant. And it does work and it will get rid of it. And most likely as they get it out, they're going to vomit with it too, which will force it out also. A 4-year-old child asked tearfully if an IM injection will hurt. What is the nurse's most effective response? Never lie to a child. Also remember today, even for immunizations, we can put some numbing cream on there, and there's no reason why we can't. It might take, put the numbing cream on, wait for 20 minutes and give it. But if a kid is like this, tearful and scared, probably he's been hurt before. I would offer that to the parent, or I'd say it's going to hurt a little bit, but it'll be over with quick. What would you want to do? And I let the kid make the decision. Where is the best site for giving an IM injection to a 15-month-old child? And that's your vastus lataris muscle that is in the right upper thigh. We don't put anything in a buttocks area on a young infant at all. And deltoid is for adults. An infant, 15-month-old, oh no, only in the vastus lataris. And they say you don't even go to the ventrogluteal until a kid can walk well. And then you would do it there, okay? What factor does the nurse explain affects the infant's physiologic response to medications? So we know children, everything is slower and it's immature. They have decreased secretion of hydrochloric acid, slower metabolism. We have a faster intestinal transit, but it's the kidney function that's immature. Of all of these things, that would make you think about, the effect of medication to an infant. Let's see how we did today. Number 3. Liz, good job, Liz. Number 2, Garrett, good job, Garrett. Number 1, Shannon, good job, Shannon. Number 4, and Cynthia, good job, guys. So that was your Kahoots for today. So we have a quiz to be taken. So what I want you to do is to go to your modules in Canvas. Remember, next week, you do have your exam, so come prepared. Anybody who needs any tutoring or help with math, please message me and I'll work with you figuring out a time. If you say you have a half hour, I'll work with your half hour. I don't want to make you feel like, I get you online, I'm have you there for 2 hours. It's up to you. What do you need? Okay, it's all about you. It's not about me. Once you are done with your quiz, you may leave class tonight. We actually made very good time tonight. So I will see you next week for an exam, or I'll hear from you if you need me, okay? Good luck, everybody. I'm gonna go off camera and I'm gonna go silent. Anybody who needs me from now on in the chat, so we're not talking over everybody taking the quiz. Good luck, everybody. Trace, put your camera on, please.
I'm done. I'm sorry, I'm done.
Good job, guys. Have a good evening. Michelle, are you supposed to be in the RN? Professor Morris's Zoom.